Hey, welcome back. Now I will talk on keloid. A keloid scar is enlarged, raised scar that can be pink, red, skin colored, or darker than the surrounding skin. Keloids are usually induced by trauma and commonly follow ear piercing, burns, scalds, and surgical procedures. The resulting keloid is larger than the initial area of trauma to the skin. Certain individuals are predisposed to keloid formation. A familial tendency or the presence of foreign material in the wound might have a pathogenic role. So there is a chance of having a familial tendency to develop keloid after certain injuries such as ear piercing. And also the presence of foreign material in the wound exaggerates or worsens the formation of keloid. Keloids are a rare feature of certain syndromes such as Ehlers-Danlos syndrome. Keloids result from an abnormal fibrous wound healing response in which tissue repair and regeneration regulation control mechanisms are lost. Collagen production is 20 times than seen in normal scars in the case of keloid, and the type 1 to type 3 collagen ratio in that wound is abnormally high. In keloids, tissue values of tumor growth factor B and the platelet-derived growth factor are elevated. In addition, fibroblasts are more sensitive to their effects and their degradation rate is decreased. When we see the clinical manifestations of keloid is a sharply demarcated, benign, dense growth of connective tissue that forms in the dermis after trauma. In this case, there is no risk of transformation to malignancy or cancer. The lesions are firm, raised, pink to hyperpigmented and rubbery, and they may be tender or pruritic relief. Sites of predilection are the face, earlobes, neck, shoulders, upper trunk, sternum, and the lower legs. In both keloids and the hypertrophic scars, new collagen forms over a much longer period than in wounds that heal normally. When we see the histology of keloid, a keloid consists of walled and interlaced hyalinized collagen fibers. And the most confusing or top differential for keloids is a hypertrophic scar. Keloid should be differentiated from hypertrophic scar, which remain confined to the site of injury and gradually involute over time, whereas keloids goes further than the site of the injury, whereas hypertrophic scar is limited to the site of injury alone, and keloids do not involute over time by themselves, whereas hypertrophic scar gradually involute over time. Young keloids may diminish in size if injected intralesionally at 4-week interval with triamcinolone suspension. And large or old keloids may require surgical excision followed by intralesional injections of corticosteroid. Otherwise, surgical excision alone causes development of new keloids which is bigger than the first one. So, large or old keloids may require surgical excision followed by intralesional injection of corticosteroids. The risk of recurrency at the same sites urges against surgical excision alone, although earlobe keloids respond well to surgical excision, pressure dressing, and intralesional steroids. Placement of topical silicone gel sheeting over the keloid for several hours per day for several weeks may help in some patients. This is all about keloid. Thank you for watching.